Hey team, before we dive into today's episode, I've got a quick favour to ask. The Women's Football Hub merch store is now live, and every purchase helps support our work as a non-profit championing women and girls football from the ground up. There's something for everybody, adults and kids. There's loads of colours and sizes, and your support helps us grow the game one piece of apparel at a time. Just head over to www.womensfootballhub.com to check it out. Thanks for backing the hub, and now let's get into the episode. Hello and welcome to the Women's Football Hub podcast. I am your host for this episode. I am Carolyn Kent, and today I'm joined by another student co-host. She's a physical therapy student from Arcadia University, and she has contributed to the secondary ACL webinar that we will be releasing across all our platforms next week. Welcome to Women's Football Hub, Lindsey Cornish.
Hi, thank you for having me, Carolyn. Very glad to be here.
You're very welcome, and thank you very much for all you've contributed, because I was very pleased when I saw that webinar. I'm sure everybody else will be very intrigued when they see it.
Absolutely. Thank you very much. I'm glad for all the work you've done and just any way I was able to contribute. It was a great learning experience, and I hope it really helps all your female athletes to move forward with their rehabilitation.
I am sure it will. Now, we will get on to our guests because we've got two fabulous guests to interview today, and they both specialise in the treatment of ACL injuries. Our first guest is a rehabilitation specialist who has extensive experience working with athletes recovering from ACL injuries. He's a clinical specialist and research scientist at the Children's Hospital of Philadelphia Sports Medicine Centre and part of the adjunct faculty at Arcadia University. Welcome to Women's Football Hub, Elliot Greenberg.
Hi, Carolyn, Lindsey. Thanks for having me on. It's a pleasure to be here.
You're very welcome. Thank you very much for giving us your time, because I know how busy you are. And obviously you've been specialising with kind of youth athletes for a little while, is that right?
Yeah, just about the last 18 years or so.
It's funny when students come in and tell me their date of birth now, that's when I start to feel, I'm like, yeah, I'm definitely now middle-aged. There's no doubt about it. And I sometimes ask them about bands and things now, and I'm like, you've never heard of them? Like the Beatles, you've never heard of them? So it's quite the education.
Yeah.
Now, our second guest works as an orthopedic surgeon at the Children's Hospital of Philadelphia and is a director of the Sports Medicine and Performance Centre. He specialises in treating high-performance young athletes. Welcome to Women's Football Hub, Dr. Ted Ganley.
Thank you, Carolyn. It's an honor to be here. It seems like a fantastic program.
Oh, thank you very much. I have to say, when I got both of you on at the same time, I was like, I've hit the absolute jackpot tonight. I'm really excited about it. So let's kind of start with you, because people don't want to hear me. They want to hear both of you. So Elliot, can you start by kind of telling us a little bit about your background and what led you to specialise in ACL rehabilitation?
Yeah, so I've been working as a physical therapist now for more than 20 years. And the clear majority of that, about the 18 years or so, has been here at CHOP and specializing in young athletes. And just by the nature of how many ACL injuries we see within this population led me down the pathway of having this as a specialty area of practice. My clinical interests in treating this patient population drove more of a research interest, and I went back and did a PhD part-time and was able to then carve out some of my time in my schedule to do some research and clinical practice. So a large majority of the research practice that Dr. Ganley and I share together is based in ACL, and that grows those clinical questions grow into research questions, and then our research drives our clinical practice. So it's got a nice system that we have here.
Yeah, it's a nice thing, because I actually find that some of the best questions actually come from clinical practice, don't they? And I think that's probably the way it should be. Clinical practice should drive the research, and then the research should give the answers to clinical practice for patient care. Ted, let's talk to yourself. What made you specialise in orthopedics, and specifically with children?
So I'd say as we go through our training, we find that what we enjoy the most, and I found orthopedics to be the most enjoyable, with exciting things that we can do to help people heal and improve and get better. And I was volunteering in quite a few sports events. And then, so I did several fellowships, one in sports medicine, and then one specifically in pediatric sports medicine. And that was because I was just inspired by the young athletes and all the work that they do to get back, and the collaborative nature of the families working with the kids. So that's what brought me to this field.
Nice one. When we talk about rehabilitation of young athletes, right, we know that female athletes or young females are typically more likely to tear their ACL. Is there a difference between kind of rehabbing young female athletes as opposed to adult and male players? Do you find that in your practice?
Yeah, certainly females seem to have a few differences than their male counterparts that make them more susceptible. They tend to be a little more quad dominant. Their quadriceps can sometimes overpower the hamstrings a bit. And Elliot and the team work to really balance those things for preventive measures and also post-op. They have a lot of advantages. They tend to be in ways that are mentally, emotionally more put together than many, at least in the US, of our male counterparts. So they've really been able to deal with the rehab component of that and sometimes next level abilities. And we really enjoy dealing with the female athletes. Unfortunately, I did what's called a systematic review meta-analysis of the world's literature. And we looked at the incidence, the percent chance that you can get injured in any one sport. And historically, it was considered that football, American football, was the number one sport for ACL tears. But the female soccer, in our country, soccer or football, as everyone calls it, it turned out to be greater than guys football.
And from a practical standpoint, I think when you contrast adult kind of rehabilitation to younger athletes, I think we tend to be a little bit more conservative, particularly early on in terms of some of the bracing that you'll see after surgery within our population. But we tend to use bracing for protecting them a little bit, not just to protect them from themselves and maybe some of the decision-making that they might lack and the insight into the consequences of some of their actions, but also their peers, right? So they're in school, they're in other environments where they're surrounded by other kids, might be more impulsive. So I think from a practical standpoint, it's a little bit more of a conservative management early on with them.
So let's talk about barriers to recovery then. What do you find are the biggest barriers to recovery for sort of young female athletes and especially in soccer players?
I'd say somewhat depends on the age. So when we talk about barriers, right? So we treat pre-adolescents as well as adolescents, and we go into young adult as well. And we think of some of those pre-adolescents specifically, they don't build muscle mass as rapidly as their older counterparts. So we work through. And then there's a component of that these very young kids are sometimes getting the same injuries as the world's most famous athletes. And it can be the dreaded injury for even professional athletes at the highest level who have incredible resources at their disposal. Therapists, athletic trainers, and coaches, and motivational speakers. And they've got all those people, and we're dealing with a young child that gets exactly the same injury. And it's that collaborative effort with the surgeons, and critical to that is the rehab therapy component to that.
Yeah, I think that example was just so illustrative. The world-class athletes had the same injury and such support. And I do think the lack of support, particularly when you move into these middle and later phases of rehab, when maybe there's insurance issues that might limit the amount of treatment that we can provide for them in clinic, and you start to lean on external people to help guide them. And if a lot of these kids won't have the support structure around them to help facilitate that recovery, which means we either have to educate them, we have to try to provide it from a distance, we have to help the parents, help them manage. And it's really, it sets up this unique challenge from a really complex recovery. And then you have this added layer of complexity on top of it without the support structure around them to provide the guidance that they might need. I think one of the other barriers that's unique to the younger population is just the loss of activity for these kids, right? It's like an itch that needs to be scratched, right? They have to get out. They have to have an outlet for this energy that they have. And when they have this injury and early on and they're under these really rigid activity restrictions and they can't scratch that itch, it becomes really challenging for them and problematic for them. So really trying to find safe and effective ways to get out there and be able to engage in as much physical activity as they can, but keep them safe and guide them in the pathway of recovery is another, I don't know if it's a barrier, but it's a challenge that they face that's unique to them.
All right. Let me bring in Lindsey here, because you've got a few questions around growth and development, Lindsey, haven't you?
Yeah, thank you. We know that growth and development can affect recovery timelines. How do growth plates, skeletal maturity, and hormonal changes impact ACL rehabilitation in young athletes?
So I might start by saying some of that growth plates and skeletal maturity are things that we look at. And so that their degree of skeletal maturity will dictate the surgical procedure that they have. So there's kids that have wide open growth plates, and they will have growth plate avoiding surgery. And then we'll have kids that are approaching skeletal maturity. And I use the term growth plate respecting. So we'll go across the growth plate itself. We'll use a soft tissue graft only. And those grafts can be stronger than the native ACL. You can get a graft from the quadriceps or hamstring or iliotibial band or bone tendon bone, and they can be all stronger than the native ACL. One of the challenges if you're using bone is that if that's at the level of the growth plate, that will shut that down. Hardware placed across the growth plate can shut that down. And then the other component to that question, I think, as you said, there's skeletal maturity and their growth plate. So kids can be one chronologic age, and you can get a class picture, and some will have growth plates that are closing, and they're much taller than everyone else. And there's others that look like they're younger, and their growth plates can be wide open. And in the end, they can be taller than everybody else. But they're different stages of skeletal maturity, even though they're in the same chronologic. So we tend to get these bone age films. You can get wrist film for bone age, or we did a study about getting bone age from an MRI of the knee as well, and that kind of a shorthand version of that. And there was another one out of Southern California, which is very good as well. There's many ways to evaluate that. You can evaluate maturity. There's Tanner staging, but as orthopedic surgeons, we tend to use bone age a little more because we're getting those films anyway, and we can read that and get that result immediately. In terms of hormonal changes, people ask about was there a susceptible time in the cycle that they can get ACL tears. And I have one of our research coordinators, she tore her ACL and she's working on this, and she is delving into that topic. And certainly that's taken into consideration. We're doing an analysis of that right now. We don't have a result. We don't think we're going to get definitive results. It seems to be multifactorial. There's lots of different factors involved with that. And certainly Elliot can comment on the rehab component of all these.
Yeah, there's been a lot of literature looking at how graft type affects rehab and recovery. And certainly graft type will have an influence on them. And we're seeing these are quad tendon autografts. Dr. Ganley and I just published some research on that, looking at the recovery pathways and that. But now we're diving a little deeper into those kind of younger kids, right? These pre-adolescents and these wide open growth plates. And we're looking at recovery patterns for them to try to understand, are there differences in this level of recovery? Do the hormonal differences between once you are pubertal versus pre-pubertal, are they influencing the strength outcomes? We know that it's harder for kids that are pre-pubertal to put on muscle mass and hypertrophy, but potentially the impacts of the early quad inhibition that happens in surgery, that will be less impactful or different based upon the surgical procedure that's done, or the graft choice, particularly when the really young kids and the IT band graft is utilized. So we're in the process of continuing to look at that in terms of our research, but there's probably some influence there, but specifically wouldn't be able to state that like right now.
Okay. Thank you. That's very interesting. So for our next question, there's a growing discussion around the mental and emotional challenges of ACL rehab. How important is psychological support in recovery, and what strategies do you recommend?
So I would say that we've been delving into that for a number of years now. It actually took us 5.5 years to get patient-reported outcome measures. Historically, it was physicians who they got an x-ray and the bones were straight and they were happy, but we want to know how the patients feel. And so we used PROMIS, patient-reported outcome measure, which is a national system for collecting that data. And why did it take us 5.5 years? We collected depression and anxiety scores. And the challenge is if they're really off, you have to tie that in with our psychology and psychiatry departments need to be immediately alerted. And that's what was our stumbling block. You can pull something out of a sheet of papers and have someone fill it out, and you can do that immediately. Or we did it through our electronic medical record. And so patients can look at that and refer to that, and this can be instantaneously transferred, and we can analyze that. And then the other component of that, we've worked in the process. Some of our sports pediatricians had some special training in psychology. And then also, fortunately, we have a sports psychologist. We didn't have that starting out in the sports center, but we've been very fortunate. So we do have kids that they don't meet criteria that are considered red alerts for anxiety or depression. However, the parents say that being a footballer is who they are, and therefore their identity has been affected. So we'll send the kids, and we describe it as to say that some of the biggest, world's most famous athletes, they have a sports psychologist. You can have one, and it can help you through a tough time, but it can also help you with performance. So we like to to look at that in a positive light?
It's fun in preparation for this. I love this question. But it's a question I never actually asked my patients. I always had my feelings of what are the hardest things? But I never asked them. And in preparation for this podcast, I asked a few of my ACL patients, I said, what is the biggest challenge for you recovering from this? And none of them said pain. None of them said lack of range of motion. None of them said quad strength. All of them talked about the emotional challenges and the psychological challenges and that loss of sport identity and being able to like not be part of their team, right? Because all the teenagers, who are you? And their sport is really up there, right? I am a soccer player. I am like that. This is what they talk about and how they identify themselves. And when they lose that aspect of life, or they feel like they've lost that aspect of their life during this recovery, is a big challenge. So I think the identifying that and maybe the formalized, maybe sports psychology if it's available to them, but doing your best to keep them engaged with their peers and socially, whether that's on some level with their team, is for most of them find that helpful. Some of them feel more sense of loss when they're on the sidelines and they like maybe feel more disconnected that way. But the majority of them, if you can keep them engaged with their team in some way and help them still feel that part of their life is still there, that seems to be helpful for them.
Yeah, I think all players as well can be different, can't they? Some like to be involved, and then some sitting on the sideline watching for some is absolutely, they're just like, I can't do that. Then it's just about picking your patient and making sure that they're doing okay. Because and I've said this before, I mean, I tore my ACL when I was 19. It's a long rehab, and I think psychologically, I think we're getting better at recognizing that and how to deal with it. But I think there's probably still a bigger recognition. And one patient actually said to me, where the mind goes, my body will follow. And she said to me, when my mind's not good, my rehab's not good. And I think that's it. It's always something to think about. Now, if we take it into the actual rehab process, so we think about the sort of first 6 months, right, post-surgery, we know obviously that in ACLs, we do typically look at certain milestones. Is it different for youth players? Do we have the same sort of milestones in youth players? And bearing in mind, there might be some students listening to this that have never seen a sort of pediatric population with regards to ACLs.
Yeah, I think the milestones are going to vary based upon who you're speaking with. And I think that we did some research not too long ago looking at variation in rehab practice patterns across just ACL in general. And there's really wide variety in what people use as their particular milestones. But I think the overall agreement you can say is that you definitely want to use milestones and objective kind of tests and measures to help you improve your decision making. So we emphasize that throughout the course of care. We like to utilize milestones in order to help make those determinations of when they're ready to get rid of their brace, when they're ready to start walking without crutches, such as even simple things like straight leg raise without a quad leg, right? Those things, lateral step down tests. We try to look at knee control when we're doing that to make the decision of whether or not they're ready to get rid of their brace and their walking mechanics. As we move forward in that rehab process, objectifying their quad strength to really understand where they are in recovery. Don't just guess on how strong their quads are. Make sure that you're testing to assess. And whatever the thresholds that you might utilize for the progressions when it's return to impact loading and jogging to return to agilities and sports activities, those might vary for your limb symmetry indexes, or if you're looking at absolute quad strength relative to body weight. But using those objective measures and those guidelines to improve decision-making is important. But you'll be hard pressed to say these are the exact tests that you would recommend across the board for everybody at this point in time.
And we found that we were really happy with our milestones and the work that our physio team had done and in creating that and doing that collectively. Changed our wording because our patients were interpreting things that we didn't necessarily expect, right? So that we had them doing hop tests and running and then side cutting in the gym. And they decided that means you can do that same thing in the rain on a slippery surface with all kinds of people, young people around who are running into each other and sometimes taking out the feet and the knees of our patients. So we actually put down some more specific guidelines and the wording for families. And then as a general guide, we did a pooled data analysis and came up with functionally a rule of nines. And Ellie can go over some specifics of fine tuning once they reach these milestones. But functionally, we wanted our patients to have at least 90% of strength compared to the opposite side, at least 9% on their functional hop testing or muscular proprioceptive balance training, and then at least 9 months from the time of surgery. And we tend to say it's 9 to 12 months because some of these much younger patients have a harder time getting to that. And then there's specific return to sport criteria, and I'll let Elliot cover those things.
Yeah, I think that the other impact of the milestone that's important when we're dealing with the families is when you give them time frames, they get stuck on time frames. And that's all they want to see. And kids are so used to being graded, right? This is where you're supposed to be. And you pass or fail, you get a good grade, you get a bad grade. And where if we soften that language, kind of what Dr. Ganley was saying, like we've also noticed that we've had to soften the language in terms of like our expectations and give them time windows. Like we will begin testing you around these time frames. And then we've found that just adjusting the way that we present the recovery patterns and the milestones to our parents and our patients reduces that anxiety level a little bit of everyone's follows their unique recovery through this process. And some people take longer, some people take less long, and we can move them through. And these are the milestones we're looking for. But they get hung up on that. I'm supposed to be doing this and it's 3 months. Like you said, that might impact their mental state, and their mental state impacts their physical states. We tried to maybe adjust the way we present it, adjust the language, make it a little bit more. These are around we start testing. These are the milestones we're looking for. And once you achieve those, then we can start to progress through there and specifics and within each of those phases for recovery.
Yeah, you touched there a little bit about educating the player, and you have to be so careful with language. You're right, I've had that before. Just because you're doing X in the clinic doesn't mean that you can do that on the field. And yes, no, also not with the ball is the other thing, And it's about, I think sometimes with younger players as well, they think they're bulletproof. And I think there's that element of, and you like that confidence in a young person, but at the same time, you also have to go, we know the risk. Now, you spoke about education there and educating the player and kind of using specific language. Do you have to do a lot of education with coaches and parents? Do you have to kind of get involved with coaches, or do you just kind of leave that for the player and the parent to hand over?
Parents need to be like your ally, and education goes a long way in making sure that the expectations are set correctly and they can reinforce the expectations for recovery with the child at home, right? And you want to make sure everyone's on the same page, because you don't want disconnect and discord, especially between parent and child. Sometimes that relationship is complicated, and you can't be nagging your child to do their exercises all the time, right? But you want to make sure that everybody is working towards the same goal and reinforcing it. So a lot of times we help align everyone together and make sure that there's no disconnect at home so we can facilitate that relationship. Coaches, it's a little bit variable. I think it depends a little bit on the level of play that the athlete is engaged in, where they are in a spectrum, school teams versus travel teams, and then rec teams. Not all the kids we treat are future D1 athletes. A lot of the kids that we treat will have a high school career, and then that's as far as their sports career is going to go. And the coaches at some of the other levels don't have the intimate knowledge or the time to help guide one individual back to their on-field kind of recovery. So it's a challenge that is leveled upon them, but if we can help with that we try to be as helpful as we can, and we are more than happy to speak with the coaches, or if there is any staff around. The more higher level teams, I feel that the coaches are more proactive in asking questions, and we signed the HIPAA forms to allow us to communicate directly with the kids' coach and give them the specifics of what they can and cannot do. But I feel like it's more challenging for those kids in those other environments that maybe don't have that level of focus from their coaching staff.
And I would say I'd love feedback from coaches and parents, even the coaches directly or indirectly. Sometimes I'll get the patients will say, my coach tore their ACL. And so I'll say, we're going to be fine because they have understand at another level. And even for families, I say that the surgery is functionally like we're climbing a mountain, and the surgery is like the helicopter ride to base camp. And then we're trekking up that mountain together collectively. And so that means that literally the parents are carrying the bags at the surgical day, and we're giving advice and carrying the bags, and we're working with therapy, and we're working with your nurse practitioner, or athletic trainer. And so I actually was fortunate to have worked, I'm going to say this, I guess it's 24 years ago in Kathmandu, Nepal. I helped walk some amazing surgical team members there through an ACL, which Kathmandu University Hospital. So it was an honor to work with them. That's when I started that analogy. I had a grandmother who once we did the surgery, and she said, let's everybody hug because it's over and it's all finished now. And I said, no, we're just starting. So that's when I started that analogy.
So as a student physical therapist, like I'm learning there are so many rehabilitation exercises that are essential to ACL recovery. Do either of you want to touch on any key rehabilitation exercises that you believe are essential but often overlooked in standard ACL rehab?
Yeah, I can start with that. I think that the importance of battling the AMI, arthrogenic muscle inhibition, that happens early after ACL is really important, right? So controlling it's the basics, right? I feel like those are, everybody wants to get on like the fancy and fun, like crazy exercises that you see on Instagram, but you got to cover all the bases first. So dealing with the AMI is super important. Getting those quads back online first. The importance of, I think, using NMES is maybe overlooked within a lot of clinics. Troy, we started a program where all of our ACL patients are getting a home NMES unit that goes home with them, so we can have this. And they come in for preoperative education with us, where we go over the postoperative protocol, but also we go over, this is how you're going to use your stim device. So we try to get them into PT early, right? Within the first 1 to 2 weeks, we want them in our doors to see us. But a lot of our patients are going to see external PTs. Sometimes there are complications with insurance. They can't get there. There's transportation issues, right? So we want to make sure they're set up for success. And I think that NMES is a really important part of their recovery to make sure they're getting their quads back online. The other thing that I think often gets overlooked is the restoration of full knee extension. Again, another really basic thing, but when they're battling and there's that 2-3 degree loss of knee extension, that really continues to drive quad inhibition, and it really does not allow them to restore a good and effective quad set. So while it's a very small loss of knee extension, you really have to make sure that you're getting them into that full knee extension position and restoring that as quickly as possible. And sometimes the simple thing like making sure you're doing patellar mobilizations, right, might give you that final couple degrees. And those are I think, overlooked things. Like patellar mobs seem so simple, but sometimes when you do it and you get them dropped in, especially with the quantum autographs or the bone patellar bone autographs, right? You can get in there, loosen things up, and then they're getting full knee extension and they drop in a wonderful quad set at the end of the session. You're like, yes, I feel good, right? You don't know how exciting that is for a guy like me to see like a good quad set, right? So I think that those are things you really, the fundamentals, those basic, really getting those key things. And I think if I had to pick a third thing that often gets overlooked is just this safe progression of open chain knee extension activities for your post ACL athletes. Okay. You can start them in isometrics. You can start to move forward with those, but making sure isolating quad strengthening, really getting that back as soon as we can.
You're going to be on Dr. Lynn Snyder-Mackler's Christmas card list for saying that. I listened to her in 2018 at the New Camp saying, if I have to come here one more time and tell everyone that open kinetic chain quads are safe, I'm not coming back if I have to do this. So yeah. Ted, we got anything to add there?
Yeah, so I'd say that we're working hand to hand. I'd say I like to be able to support those principles that he described. So intraoperatively, we want to make sure that we've addressed every aspect of their stability. Back in the quote unquote old days, they weren't sure about their ACL, so they'd immobilize and cast for long periods of time. So we want to fix it solidly and then move it immediately. So we tell the patients, I'll tell them, you can take today off if you're at a day of surgery, so they're not completely waking up from anesthesia, but starting tomorrow morning. And if you want to, you can start that night, but we're going to work on motion tomorrow morning. So we're going to do that immediately. And then we dialogue with Elliot and the entire team to make sure we have a plan. We like to be physically next door to physical therapy. We have sports sites that are immediately adjacent to where we're seeing patients. So it's all collectively a sports center. It's not just physicians seeing patients, or not just physician assistants, or not just physical therapy. We all work together with that. And then we'll get reports that we'll create a plan, and then we'll send that, even if they go from a distance, a long drive or a plane flight, we want to send them with that. And they're welcome to institute any of those things that we have in their program for that each patient. So we think that's a key, is communication for that.
I'm always amazed like how quickly post-op ACL patients are allowed to do range of motion and just get moving. I think it's amazing like how far research has come. In addition to range of motion and strengthening exercises, how much emphasis should be placed on neuromuscular control and biomechanics in ACL rehab?
Yeah, there's so much evidence in terms of at least primary ACL injuries, like the influence of movement patterns, right? And at-risk patterns that place you at a higher risk for ACL injury. It has to be a component of what you're working on, and it happens early on. And if you think about it from the standpoint, 70% of these ACL injuries are non-contact injuries that you're probably fighting an uphill battle, right? These poor movement patterns or at-risk movement patterns, might be a better word for it, right? Were probably present prior to injury. And now we're having them in their recovery pattern, and we need to undo some things that were already present that were maybe not the best. And we also need to try to work on restoring all of the new deficits that are also resulting as part of the surgery and the recovery. And there's many phases. I feel like I always say to my patients, like, being strong is one good thing, but being able to access that strength quickly is another thing, right? Even early on, working on neuromuscular control exercises can be something as simple as working on timing of your quadriceps contractions. So maybe having them work doing quick and short, like isometric pulses, is something that we try to facilitate in order to work not just on the strengthening component, but now, hey, we're going to work on that timing of your quad. Can you turn it on, turn it off really quickly and be able to access strength, start to work on that neuromuscular more control component of that. We try to make sure we have checks on ourselves as we go through this. So we look at even early on in our recovery pattern around that 3 to 4 month time window, we will make sure that one of our milestones that we do utilize is lateral step down tests. So before they're doing any kind of impact or jumping or loading, we're just going to make sure we look at their lower extremity control in a structured, validated format. And we chose to use the lateral step down as a good, easy clinical measure. We're not using like 3D motion analysis or anything of those lines, just visual representation from our therapist, but looking at both their involved and their uninvolved legs, right? So making sure that we're paying attention. If the contralateral injury risk is just as high, why are we going to not address any of those issues that we might see as present? So we're going to try to get on that early and see if there's any neuromuscular control issues that we can start to address early in their recovery. So when we get down the pathway and we're starting to look at return to sports, we're not saying, oh, this doesn't look good now. We need to work on that stuff. You've already been addressing it on either limb throughout the duration of their rehab.
I would say Elliot and I did a study where we looked at footballers, female and male, and we went to their training facilities and we showed that they couldn't pass our return. There's a certain percentage of kids, I should say, that couldn't pass our return to sport ACL program as active soccer players, right? So they didn't injure their ACL. They didn't go through the rehab, so sometimes I think kids if you get a t-shirt and you can go on a field and you can play and the entire town is out there. But so we have we have an injury prevention program and we've incorporated that into our rehab, which I think is really important. So I say you're getting neuromuscular proprioceptive training while you're going through this process. You're getting for your affected leg and your unaffected leg. And that is a key component because we'll give them that and send them off when they're getting back to activities. And we want them to maintain that fantastic success that they've had, and we don't want it to disappear. Some of the programs are hour-long programs that are 5 days, early on it was 7 days a week. And we find, I don't think that anybody these days has really 5 to 7 extra hours in their week. So those have been condensed in that. And I thank Elliot and a colleague, Jeff, for that as well. They did a fantastic job with that.
Let's move on to return to play. We're thinking about going back to return to play and those sort of long-term considerations. I like to do a little bit of sort of myth busting or just making sure we underline key points here, right? So everybody talks about HOP tests and strength tests, and you mentioned the rule of nines and 90%. Is that enough? Is that enough for somebody to go back and play? Do they need more?
I think it's clear it's not enough, right? Because we have such an issue with re-injury rates, particularly within our younger athletes. So the evidence is showing us it's not enough. And I think, my view over the years of practice is a lot of the current criteria that we're looking at is, are you recovered from your surgery or not? And I feel like that I can make a very sound decision. I feel like that of using within the current reference that we use in our assessments that we use. Are you recovered from your surgery or not? Are you at risk for another ACL injury? These tests are not giving me that information. I think we're exploring this. Dr. Ganley and I, we just published a paper this month in OJSM. We're trying to use a little bit more advanced machine learning techniques and using a lot of the data that Dr. Ganley's been collecting since 2009. And we've been looking at machine learning algorithms that might be able to help us find some more nuances in how we're making connections within our existing tests that we use that might do a better job of identifying re-injury risk. But I think as we continue to learn more, that we do need a more comprehensive approach. And the data's coming out now and looking at some of those more kind of contextual factors and the psychological factors that might influence that, and some of those things that are being more defined now. But I don't think we have the right answer yet. And I think that there's so many great people doing lots of really good research on this topic that I think our knowledge of this will continue to grow. But the balance between the number of tests that you're using, right? Because as you start to just throw more and more tests in there, it's likely that people aren't going to pass all of those tests or have satisfactory scores in all those tests. So there is an issue where you have to worry about just doing too many tests. And as Dr. Ganley mentioned, our own research shows that a lot of healthy kids aren't passing the return to sport criteria anyway. And a lot of our post-op ACL patients aren't passing all of the current criteria. Like if you look at best practice, that they're not passing all of that. So maybe using decision makers like pass, fail is not the best framework, but starting to lean on some of these, our thought processes, maybe leaning on some of these machine learning or more advanced kind of data-driven decision makers might help us be able to classify people a little bit differently and more at risk, less at risk. And let's talk about how we can move you down the spectrum to like less risk. I think that the way we talk about it now and the way families interpret what we talk about now, they figure clear is I'm good to go. I'm cleared from my sports. I have no higher risk of re-injury. When within our population, and it goes across the board with many injuries, like the highest risk factor for any injury is having that injury to begin with. So if they have an ACL injury, now they're at high risk. And a lot of these kids, they tear their ACL at 14 or 15. We're releasing them back to sports at 16, 17. That is the highest risk period of their life. So they're already high risk. And we put them back on the field at the highest risk part of their kind of sports career, that we really want to do our best to help them understand what their risk is and help them make the best decisions in terms of sports participation and activity.
I've even used the phrase during rehab, they'll come back and they'll be meeting with Elliot. And I said, I don't use the term a strength test. I said a strength evaluation, because sometimes I had a kid who said, a test is a pass or a fail. So I'm even changing that terminology. But I was even on a national meeting, and I was on a panel, and I was challenged. It was patients treating younger and older ACL injured patients. And I was challenged to say, your re-injury rates are higher. And why is that? So I actually showed a video of one of my patients was on one of these national cheer competitions, and she tumbled across the stage as 4 different athletes tumbled in different directions. And I said, okay, so the ACL re-injury rate is significantly higher under the age of 25. In this patient, she tumbled between 15 and 20 hours a week. And so I said, how many in this auditorium know of an adult who does tumbling 15 to 20 hours a week? And I said, how many in this room know of any adult over the age of 25 that tumbles once in a week, in a year? And I didn't get any hands raised. And so I think we're dealing with, it's apples and oranges in many ways.
So getting into return to play and long-term considerations. So we're getting back into sport here. What are the most common mistakes that young female footballers or soccer players make when returning to sport after ACL surgery?
I could say that we did something called an uproar study, unplanned return to OR. And actually 44% of our patients had a return to the OR for any reason. It could be for meniscus, it didn't have to be for ACL re-injury. It could be for anything, and 44% of those patients were not following our ACL protocol, if you will. And so that's when that was a consideration when we changed wording. So we've adjusted things over the years based on that. So I think that's significant. I think we have patients that we've gone over the criteria and what we want them to do, and they've said 3 months in, I feel fine. So I'm going to do whatever I want to do. So that's a job that we have with the parents, with the other family members, with certainly our physio rehab team is doing a great job with that.
Yeah, I think one of the other common mistakes that I see, once the kids are so excited to get back on field and playing their sport, that they forget about doing their injury prevention and doing their ongoing strength and conditioning work. And I think that is another important factor, that if the kids don't have the support structure around them to make sure that they are doing that, putting in that extra time, it's not something that a lot of times their team is not focused on this. A lot of the practice structure that typically where the kids will get guidance in their activities, this is something extra. It's extra credit that they have to do and make sure that they're doing their injury prevention. So if the coaches or trainers aren't available to help make sure that they are doing it, it falls on their responsibility to do it. And a lot of times it gets overlooked. Maintenance, that's the kind of important factor.
Yeah, doing your home education or your home exercise program is just so important. So there's growing evidence that ACL injury recurrence rate, like we talked about earlier, are higher in females than male athletes. How would you both say we could reduce re-injury risk once athletes return to full training and their matches?
Certainly, I tend to start with athletes in the first season back. I generally start, and I talk to, again, our female athletes about saying, I'd like you to start in your first season. And this, I have to say, I say for both females and males, but my rule of thumb is I like you to start with one sport, your favorite sport, one team, your favorite team. So I don't want you to play three different sports, and I don't want you to play on one sport, but you play the school team and the club team and the AU team and the Olympic development team, right? So I want you to be aware of those athlete hours of exposure. In that analysis of injury, if I had males playing American football, it was 0.8% chance of tearing an ACL. If they played basketball, it was 0.2. If they played baseball, or around the world might be cricket, but it was 0.003, right? So roughly one full school year, one would be 1% chance of tearing your ACL. But our female footballers, soccer players, it was 1.1% chance for a season. And that included preseason and postseason. And statistically, it was one postseason game. So I based that on athlete hours of exposure and only sports that had athletic trainers on the sidelines. So it didn't include if somebody's riding a dirt bike in the woods, they don't have an athletic trainer sitting there, or snow skiing. I didn't include that. So there are sports that are higher, but this is the ones that applied to us. So those are some rules of thumb that I have for returning to activities, and then including our injury prevention that was incorporated into the rehab. I'll emphasize that. Elliot, I welcome your insights as well.
Yeah, I think I'm going to repeat what I said already, right? That the risk reduction programs that are out there and exercises that you can do, the effectiveness has been shown in many different, like, well-structured research studies, that if you do these injury prevention programs, it doesn't matter, you choose it, right? There's a lot of different examples that are out there, and there's principles that need to be involved in terms of neuromuscular control training, the hip strengthening that you need to do, right? Plyometrics, these factors, as long as those components are part of your injury prevention program, as short as a pre-practice warm-up or a full injury prevention workout, like they will help. But unfortunately they get overlooked, whether that's a structural thing within how just the whole kind of sports atmosphere is run, or an individual thing, like that the kids, they forget about them and they don't want to do that. But we emphasizing to them that they need to take a little bit more care. This is something that they had this injury, and in order to make sure that they stay good, they got to make sure that their body is tuned up a little bit better than maybe the person standing next to them that never had an ACL injury in the first place. So really helping them understand the importance of that and doing the programs that will drive their success and help them.
Let's kind of talk about the thing that probably the sports medicine community is so concerned about, these rates of ACLs. Let's talk about early onset arthritis in the knee. From a perspective, Dr. Ganley, of what obviously you might see some revisions coming back in. What's been your experience with regards to people getting early onset arthritis?
Yeah, I think that brings to the question of what are your goals of ACL reconstruction? So I say your goals should be to maintain a stable knee. We did an analysis, it was in the American Journal of Sports Medicine 2012, of patients that were treated non-operatively. And that was from a different era, but we did an analysis of those patients, and that And if they were beyond 3 months from the time of their ACL reconstruction, they had a 4 to 11-fold increased risk of irreversible meniscal changes or cartilage changes that were high grade, meaning either grade like a sweater or exposed bone. So therefore, the question is, when you're doing an ACL reconstruction, your goal is to prevent a person from having an old person's knee at a young person's age, because we've had people come in to see us with exposed bone, and then they say, can we get arthritis from this someday? And I say, you arrived with grade 4 traumatic arthritis. You don't get any more arthritis than exposed bone. That can be a little different than grandmom and grandpa who have exposed bone everywhere. It's bone on bone. But I say, you have exposed bone on cartilage. That is arthritis. We have to treat that as well as the ACL. And we have patients that come in with an ACL and they've torn their ACL and they knock off a chip of cartilage, just like I described. Or they will have that bone growth pattern on the front of the thigh bone and back of the shin bone. That can have grade 1, 2, 3, or 4, meaning softening, fissuring, fraying, like an old sweater, or exposed bone. So you have to actually, we're treating those things, and then we're trying to get you to have a stable knee that doesn't give out with activities of daily living or healthy fitness. And I use the term healthy fitness because I've got some patients that they're on a dirt bike 20 feet in the air and they pivot. I have a few professionals, they put their foot in the mud and they turn on that. And that's what they do. We support them. We fix everything. We give them fix collateral ligaments and cruciate ligaments and all those things. So we're there for them. And so there is information that says 20 years down the road, you can have a higher incidence of ACL or arthritis than the general population, or basic Fairbanks changes, right? A little joint space narrowing and spurring those findings, right? But the question is that there's an impact that you have immediately. If you took something like a cricket racket or a baseball bat, and what would it take to create the size bone bruise that we see on a femur? It would take a lot. And there's impact in that cartilage. So some of that arthritis occurs at the precise timing of injury. And we can't necessarily prevent, it's not designed to prevent arthritis for you 20 years down the road. It is hopefully helping you have all of these changes at a very early age, which we have seen walk through the door. So I have had that conversation more, as you can imagine, more than once. And I feel passionate about the fact that we're dealing with challenging conditions and early traumatic arthritis the day that they arrive.
So obviously strength and conditioning is just so important to long-term care after ACL reconstruction and surgery. But can you just touch on what role does it really play in long-term knee health for young female footballers or soccer players post-surgery?
Yeah, I think there's lots of good, strong evidence showing that restoring full knee range of motion, right, particularly knee extension, restoring normalized gait mechanics, adequate quad strength, like this in terms of protecting the cartilage and long-term knee health, right? So I think that it comes back to those basics, right? Making sure that we are giving them a strong platform to work from and making sure that we have those basics covered. And then moving forward, maintaining that and allowing them to have, from a activity standpoint, maintain like an active cartilage healthy exercise program for them moving forward. Strength and conditioning is challenging in adolescence overall, I feel like, but particularly for female athletes, that a lot of programs in high school or middle school don't have strength and conditioning professionals available to them. And so the training, the exposure comes from either they're just going to the gym and trying to mess around on their own. Maybe they took something at the YMCA or their local gym that kind of showed them maybe like some basics on some machines, or potentially a coach gives them a program and says, go do this, but they're not taught lifting form, or what they're doing it is not structured enough for them in a lot of environments. I'm not saying all environments, but a lot of environments. So lack of resources is considerable. And the research also shows that, particularly for female athletes, that this is a challenge for them to get into the weight room. They don't feel comfortable. A lot of them don't feel comfortable in weight room environments. And especially in the high school environment where they're sharing the weight room, maybe with all the other kind of athletic teams, they don't have separate facilities or for different teams, and regardless of sex or gender, that they don't feel comfortable in these environments. The lack of resources, and then that extra layer of they need to get that personal challenge of feeling comfortable doing the weight training and the strength and conditioning environment just really makes it an uphill battle for them in a lot of ways.
Yeah, absolutely. Did personal fitness training before I got into physical therapy school. And I did notice that young female athletes just don't like, I've been in like a couple athletic training rooms in high schools and just during my time personal training, like just the lack of focusing on form, like in strength and conditioning is huge. So thank you.
I was part of a group that we just published a study in physical therapy and sport a couple of months ago, looking at exercise prescription in amongst physical therapists even. And what we found was that there was bias there in physical therapists. When we gave them identical patients, that they were dosing their interventions there for their late phase recovery. They were dosing their female athletes lower than their male counterparts. So even amongst like professional environments, people with good training, that there might be this inherent bias that is dealing with in terms of female athletes, like that we may not be loading them or teaching them the way that they need to be lifting or can be lifting or should be. So I think that publishing a study was important just to gain some awareness of this and try to understand like this is a problem that if it exists within our professional environment, people that would probably be aware of this and be aware of exercise prescription more so than other environments, that it probably gets magnified in other areas too. And that's as they move forward in that kind of strength and conditioning aspect of their recovery.
Yeah, that's huge. So finally, if you could give one piece of advice to young female footballers or soccer players going through ACL rehab, what would it be?
So I might say that perhaps even this evening, there's been some gloom and doom regarding footballers and these injuries. I might say that I might take an opposite approach to that and say, certainly I've had kids that have not been on any field of play ever, and parents to get them out of the house have put them on a trampoline in the backyard. And I've had a combination of injuries, which have included ACL and medial meniscus and cartilage defects like I described earlier, right? And I grant you that I will, and I've made this statement, I will fix everything. I will take care of everything, but I want you to make a commitment on your part that you're going to be my straight line athlete, right? So that there's the challenges with strength to weight ratio and rotation and alignment and all those things. But for the most part, soccer footballer athletes, female athletes come into me, and when they had even that cartilage defect, right? I described those earlier. If you put a cartilage defect back and you fix it, they went from grade 4 traumatic arthritis to cartilage, their own cartilage, not someone else's, but their own. And so not all the injuries that I described, I'm talking about now a footballer, many of whom have exceptional alignment, right? We're talking about exceptional rotational profiles, exceptional strength to weight ratio, and we fixed their knee with something stronger than their native ACL. And there's forms of reinforcements that we can give. And you've done a fantastic job, amazing work on your rehab, and your results are that we've gotten testing are exceptional. And we do analysis in the gym and in the office, and we'll say your form that you just described is excellent. And so for them, I want them to be encouraged that we've done many things and they've got neuromuscular training that they never had before. So that's just, we have this little bit of a stronger than ever philosophy, and we can get you there. We can get to the top of that mountain, and it's with a lot of expertise and it's a lot of commitment. But I think in many ways, we've prevented injuries in the future, and not just to the ACL, but ankles and other things that we've done. We've worked on their core strength and their hip. Elliot will say their short external rotators needed some work, right? So I am encouraged by the fact that I think we can make kids better than ever. And there's ways that they can intelligently get back to the things that they love to do. And football is a spectacular sport.
I think for me, if you asked me this question 5 times, I'd probably give you 5 different answers. To be honest with you, I feel like I would have a different flavor of the week every time I would answer this. But I think right now, the piece of advice that I would give, just based upon my recent patients, is like, you're on your own journey. Don't compare yourself to your friends or to others. And recovery is not a linear process, right? There's going to be some ups and downs. We're a team. We're on your side. We're moving you towards your goal. And sometimes that pathway for your goal is going to take a little bit longer to get to than maybe the person standing next to you. But try to make sure that they understand that everyone's recovery is different. we'll get you there. We just got to make sure that you stay engaged in the process and feel good and confident with it.
I cannot tell you how lovely a chat that has been. Can I just say, Elliot and Dr. Ganley, thank you very much for giving us time. I really do appreciate it. Lindsey, I know who I'm calling if I ever need a vacation. You can certainly slip into the hot seat at any point. You did absolutely amazing this evening. To all of you who are listening who are working with players with ACL injuries, please make sure that you follow the evidence. Please also remember that really we need to start looking at prevention, and a lot of prevention. And for those of you who are looking at this podcast, please remember to subscribe, and we will see you soon.
Thank you for listening to Women's Football Hub. The information within this podcast is for informational purposes only. No material on this podcast is intended to be a substitute for medical advice, diagnosis, or treatment. Please contact your doctor or another healthcare professional if you have any questions about anything raised in this podcast.